I want to start by acknowledging the traditional custodians of the land in which we meet today, the Ngunnawal people. We pay respects to elders past, present, and emerging, and we acknowledge their continuing connection to this land. Thank you all for joining us in our second choir seminar. This series is meant to showcase excellence in clinical trial research from around Australia. So it's my great pleasure to introduce Dr. Bridianne O'Day. Bridie completed her PhD in the University of Sydney in health sciences. She's an associate professor, NHMRC, MRFF investigator at the Black Dog Institute. Her research in mental health integrates different disciplines like public health, computer sciences, and psychology. She is currently leading a comprehensive research program that uses digital technologies for the early detection of mental health issues, as well as the delivery of better health care. So today, we'll learn more about her MobiliseMe study and how smartphones can become allies instead of hazards for mental health. Thank you, Bridie.
Hello, everyone. So yeah, I'm Bridie. Thank you for inviting me to talk. I could pretty much talk to a brick wall about the clinical trials that I do. And so it's always a pleasure to come and talk to people who are interested in hearing about some of the work that we've been doing. So as you know, I am based at the Black Dog Institute, which is a medical research institute within the Faculty of Medicine at UNSW. But my actual formal training is I am a generalist health scientist. So my undergraduate training was all in health sciences with a sort of a major in mental health. And I think that's really important to acknowledge because working on clinical trials, I've learned that you can never really hide away from your discipline. It always tends to raise its head along some of the decisions that you make along the way. So I too just want to, on behalf of the Black Dog Institute, acknowledge the First Nations people and the traditional owners of the First Nations people that we're meeting on. I am actually, the work that I do comes with the land of the Wongal people up in Sydney. And one of the amazing things about working with online trials that you actually get representation from all across Australia. And just acknowledging that First Nations people have been coming together and sharing stories about how to have a better life long before we have today. So I also have to start by acknowledging all of the people that I work with on my clinical trials, in particular Phil, who's been nice enough to come and show up. So in my experience, the best clinical trials are done in a team and where you really try and fill the gaps. And one of the parts I enjoy the most about with clinical trials is working together to make a decision about what we think is best. And so none of the trials that I do would be possible without the work of my team. So in today's presentation, I wanted to focus really on these three things. I wanted to talk to you a little bit about the MobiliseMe trial and why this trial now, because I think we often focus a lot in clinical trials on why we should be doing this. But another key component is, well, why now? Why is the timing right now? I'll take you through a little bit about what we did and what we found, and then some of the lessons that we learned and where I think we could go next. So in terms of why this particular trial, so the MobiliseMe trial is a youth mental health trial. And in terms of setting the scene, particularly in Australia, we all know that we do have a mental health problem. Amongst many of the health problems that we have, youth mental health is an important one. And this is because we know that in adolescence that 50% of all mental illnesses emerge in those adolescent years. So we know that there's a high prevalence rate of mental health problems emerging in adolescent years. And there is also new research to show that in this cohort of young people coming through, they don't recover. They first experience their mental health problems in adolescence and they continue to experience mental health problems all the way into their 30s. One of the other challenges is that we have 1 in 3 have 2 or more mental health problems. So a lot of the field in mental health started out working on diagnosis-specific interventions, and then we've come to learn that actually young people are quite complex. They're often presenting with more than one disorder. So we need to kind of be moving towards these transdiagnostic approaches. And also we have this other problem where 50% of youth do not receive professional treatment for their mental illness. And among those that do receive professional treatment, only 1/3 are estimated to receive evidence-based treatment. So not only do we have this prevalence issue, we have a lack of young people receiving treatment, and then those that do receive treatment don't tend to get something that's evidence-based. And in particular in adolescents, there's a huge range of barriers that actually impede their access to care. There's no one particular barrier that's shared or experienced by all. But the 2 particular barriers that my work focuses on is around tackling young people's preference for self-help. So a lot of my work is done with adolescents who are secondary school age as they start to move away from their parents for their support, and they move into the desire to solve problems on their own. And that internal developmental desire for self-reliance is one of the key barriers that the work that I do really tries to focus on. And then in addition, it's really about overcoming this lack of professional help. So we know that even if we increase the number of clinicians, we would never be able to reach the number of people in Australia who need mental health care. So we just have to look at other ways. And this is really where the interest in digital mental health care comes from. So moving towards digital, we know we've seen digital advancement in all aspects of medicine, and digital advancement in CBT. ANU is the birthplace of digitised psychological therapy. So moving forward, I think it's nearly 20 years now since the first development of computerised therapy for mental illness. We now all have access to a smartphone. And so increasingly, there has been a move away from online CBT therapy programs to programs that you can access from your back pocket through your smartphone. So in 2020, we saw the first meta-analyses of clinical trials for the effects of smartphone therapy in adolescents. And in 2020, there was only 12 trials that had examined the effectiveness of smartphone therapy. Fast forward 3 years, we have 38. So you can see that it is a rapidly growing area of research. But when you compare this to what we find in adults, it's essentially what is done in youth is less than 1/3 of the clinical trials that we see coming in with adults. So we also have this inequity in the types of clinical trials that we see in mental illness, particularly for young people. But in general, the meta-analyses have shown promising effects for smartphone therapy, essentially showing that you can deliver effective therapy via smartphone apps. But the problem that we have in Australia is that currently, at the time when we conceived this project, and still actually to this day, there's no freely available evidence-based smartphone app that can essentially reduce depressive symptoms effectively in young people. So all of the apps on the App Store were not found or hadn't been tested for clinical effectiveness, and both in Australia and worldwide, there was not a smartphone app publicly freely accessible to young people. So we were awarded a 3-year philanthropic grant to design, develop and test a new smartphone app for reducing depressive symptoms in young people. I keep going to say treat, but that's not the right word. And so Clearly Me was born. So Clearly Me, it went through a full process of co-design. So I've worked on many digital products, and Clearly Me followed all of the co-design principles. It's the most well-designed intervention I've ever worked on. We worked with adolescents, parents, and mental health professionals. It essentially breaks down first-line gold standard treatment, which is CBT for depression, into bite-sized therapy that young people can do at any time, at any place. So the way that I like to think about Clearly Me is that Clearly Me is the sandpit. Pretty much anything that the young person does in the app is therapeutic, and your job is just to get them into the app and try and keep them in the app for as long as possible. And the structure of Clearly Me is extremely different to any type of CBT program on the market. It's not sequential. As I said, it's bite-sized, and it does follow that sandpit analogy, that there's a huge range of things that young people can do in the app. And so once the app was designed and then built, it was ready for testing. So we went straight to a fully powered clinical trial with Clearly Me. We didn't do a pilot RCT, and this was simply because we felt that we had many other existing clinical trials that had finished up at that time, and we really felt that we were well prepared to go for a fully powered RCT. So I'm going to talk you through now how we actually tested Clearly Me, and some of the maybe some of the interesting things about our clinical trial methodology. So we had 3 aims in our clinical trial that we wanted to test. So essentially the first aim was that we wanted to determine whether Clearly Me as an unguided self-help app was effective for reducing depressive symptoms in adolescents who had symptoms, okay? So that was our primary aim. However, because of a lot of the other things that were going on in the field at the time, particularly in the adult literature, we were also interested in examining whether receiving guided support led to greater engagement in the app. Because in the adult literature, there has been many studies that have shown that guided support leads to greater engagement. And the hypothesis is, it's not proven, it's still a hypothesis that the more engaged you are with digital therapy, the more likely you are to get an effect from it. And so in our clinical trial, we also wanted to examine whether receiving Clearly Me with some guided support led to greater engagement. And of course, we were interested in evaluating whether Clearly Me had secondary effects on other outcomes that are important to young people's mental health, like anxiety, psychological distress, and whether it impacted the core components of CBT therapy, which is CBT skill acquisition and some core competencies, I suppose you would say, of somebody who had gone through a course of CBT therapy. So we had these 3 aims. So to examine these 3 aims, we had our 3 primary hypotheses. So the first hypothesis was that we felt that the young people who received Clearly Me would report greater reductions in their depressive symptoms at 6 weeks of use and at 4 months of use when compared to the control condition, okay? And we also felt that the supported arm would also report the same pattern. We also felt that the young people who received Clearly Me, whether unguided or supported, would also report greater improvement. So pretty standard hypotheses there around the effects. Our final hypothesis was around the difference between your guided support and your unguided arm. And our hypothesis there was that we believed that the participants who received guided support would have higher levels of engagement, but we didn't make any hypotheses around the treatment effects of whether or not that would actually lead to a better treatment effect. And this is because there are many, many studies that show that you do not get a greater treatment effect with guided support. And I'm still yet to this day to hear a very good explanation from clinical trialists as to why they feel that finding occurs. Because there is a lot of evidence now to show that really offering guided doesn't lead to better treatment outcomes. So why offer it at all? So if you ever hear one, please let me know. So our study design, we used a 3-arm parallel group RCT. So of course we had our self-directed ClearlyMe app, we had the app with the guided use. Now in our particular arm, our guided use, because we're working with young people, we used SMS-based chat. In a lot of adult trials, they use telephone calls and they use email, but we realised that through our other clinical trials that there will be no uptake of that in teenagers. And so we implemented an SMS chat arm. And in this particular arm, I'll talk a little bit more about later on, but we had a script, and it was entirely focused on engagement. There was no clinical support. It was a full engagement piece to the condition. And then we also had an attention matched control condition. And I'll talk a little bit about that in the next slide, but we did publish our protocol. So all of the detail is in the protocol. We had approval from UNSW-HREC. We have prospective registration. I wanted to talk a little bit about selecting control conditions in digital mental health trials. Now, in other fields of medicine, there is a significant amount of guidance around what control conditions you should select for your trial. But in digital mental health trials, when we were designing our study, there's very little guidance on how you should appropriately match your control condition. And a lot of the decisions simply come from consensus meetings with highly experienced clinical trialists. So we met together as a group to have numerous discussions around what control condition would be most suitable for this trial. A lot of trials at that particular point in time were using waitlist controls, which we knew was not going to be suitable because we were dealing with a symptomatic group of young people. And so you're trying to balance, your ethics with your treatment effects to what standard care, to what would be an informative trial. In September last year, sort of 2 years too late, there was a publication out now, which is a great guide to selecting control conditions in digital mental health trials and all of the factors that you need to think about when selecting a control condition. But at the time, we were simply going from our experience. So in our particular trial, we used weekly SMS psychoeducation. So we were controlling for the control condition had to be on your phone. It had to be accessed the same way that other parts of the intervention would be accessed. And it had to be as easy to access and absorb, similar to an app. So we landed on weekly psychoeducation, and the psychoeducation does have an effect size for depression. So we had to account for that in our power. So one of the strengths of this particular study is actually the use of its control condition. So I wanted to take you through now our study process and highlight along the way some of the things that we did a little bit differently. So our sample target was 489, and that was accounting for a 20% attrition rate. And as I was saying, we had two effect sizes that we had to take into account in our sample size calculation. And thankfully I have Phil who looks after that, and I didn't have to worry about it, but we landed on 489. Our participants were young people aged 12 to 17 years. So they are essentially minors. They had to be experiencing mild to moderate depressive symptoms. And in this particular trial, and it's one of the only trials to do this, the young people could not be in treatment. So they needed to be symptomatic, but they were not able to be receiving any psychological therapy or any medication or about to start any treatment. Now, as you can understand, this then creates a number of ethical considerations that you have to think about in your trial design. But we made this decision because we wanted to get to the end of the trial with to confirm essentially the treatment effects of the intervention. because one of the downfalls of some of the other trials was that they couldn't necessarily separate out the adjunctive nature of their digital intervention from the treatment that their sample were receiving. We also were not including young people who had severe suicidal ideation or recent suicide attempts. They could have some suicidal thinking, but it couldn't be severe. All of our recruitment was via social media, and this had knock-on effects, which I'll talk about as we get to the sample. Our most effective social media platform was TikTok. I don't know what those ads look like because I don't have TikTok, but all I know is that when we put it on TikTok, we got like over 100 participants overnight. And we also use the Black Dog Institute social media. They have a strong social media following. And so we recruited all of our participants online, and the entire study was done online. So in some domains, they call that a decentralized clinical trial. All of our consent was collected online, and we did collect parental consent, and that was collected via an online form, which was sent to the parents via email, and it was a verifiable form, and they got 3 reminders to complete. So all of our consent procedures were done online, and we did receive parental consent. So once we recruited all of our sample, we then had our surveys. So in our particular study, we had our baseline. They were then randomized. We had the 6-week survey, which was our primary endpoint, and our primary outcome was self-reported depressive symptoms using the PHQ-9, and we didn't have a clinician-rated diagnosis. So that can be controversial in some areas, but in the work that we do, we consider that the PHQ-9 in particular is a validated and almost gold standard measure of depressive symptoms. And then we had a 4-month follow-up. And then after the 4-month follow-up, the control group did get the intervention. So our choice of a 4-month follow-up is around pragmatic in terms of not letting the control group wait for too long, but also because the group weren't in treatment. So we wanted to make sure that they were able to access treatment, and that we know that CBT can take some time to generate an effect. So then it came to, in that initial 6-week intervention period, they were randomized, as I said, to Clearly Me, the SMS support, or the mental health SMS tips. In the SMS support, this was run by a program called Text Magic. And we had 3 people in the team who were the SMS coaches. And even though they followed a script and you could automate the script, for this particular clinical trial, it did have a person behind it. And they had a case load. It was between 4 p.m. and 8 p.m. Monday to Wednesday. And they would go in and do the SMS support. And it was quite interesting. The young people, if they got a different coach one week, they'd say, what happened? What happened to Mickey? Where did she go? Did something happen to her? And we had a standard script. So we had to say, have you downloaded the app? So they did get very attached to, well, it seemed to be that they got very attached to the SMS support. But we had really high rates of engagement in the SMS support. And then the mental health SMS tips were interactive PDFs that would be sent alongside the content in the SMS. So they were instructed to use this or review it for 20 minutes each week for 6 weeks. I wanted to talk about that a little bit because this is an area that's quite interesting to me, in that my team and I have done quite a bit of work looking at the importance of instructions for use. So this comes from the field of medicine, that when you're given a medication, that you're given very specific instructions for use, and they consider that to be an integral part of your care. So we've done some work looking at around instructions for use in digital mental health and how many trials include this. So we wrote a piece around the intervention development and what should it include. And then we also did a systematic review looking at the use and how it's operationalized in trials and whether trials use it. And really the findings of the review were saying it's a really important thing to include, that you should always give very clear instructions, and it's really integral. So we gave very clear instructions to our young people in our trial, and they were reinforced at every stage that we had contact with them. Also, with the expected adverse event monitoring, we had 4 expected adverse events, which are outlined there. So it was severe suicidal ideation at any time point, severe depressive symptoms at the secondary endpoint, and this is essentially because they're exiting the study with elevated symptoms, if they'd had a mental health related hospitalisation, and if they perceived that their mental health had deteriorated due to anything related to the study activities. And all of these expected adverse events, the young person would receive a pop-up information box, and ethics required us to have a follow-up telephone call from a clinical psychologist. Now, this is quite a controversial safety method. So I was on the UNSW HREC for 5 years, and it was really quite interesting to see how over time certain committees, which was a great committee, by the way, so it's not a reflection of the committee, but committees do start to reinforce the same safety measures. And one of them was actually Lifeline, had to be put on every single PICF, and also that they wanted a telephone call from a clinical psychologist. Now, as somebody who had worked with young people in most of my clinical trials and looked at their health service uptake, we had often found that less than 3% of young people would ever use a telephone helpline. So I often found it problematic that the inclusion of a telephone helpline was what we would recommend to young people in distress. But that became part of standard practice, and so that's what we had, and I'll talk about what we found about using that. So that's what we included in our adverse event monitoring. So when it comes to now, they've participated in our 4-month trial, and this is our final sample. So we did reach our sample size, and we actually got a little bit higher because we found that attrition was higher. The average age was 16 years. We had 5% identify First Nations. We had 41% of young people identify as sexuality and or gender diverse. Now, I'm not sure if many of you do a lot of research in young people, but this is very high. I'd done a clinical trial a few years ago. It was getting up to that rate. It was about 30%, but in my work that we'd done in schools, so in universal samples, it's not that high. And we talked a lot about this, and we think this rate happened for sort of 3 factors. The first being that young people are more comfortable identifying in these different subgroups in 2022 when they did the trial. The second is the Black Dog Institute is perceived to be an ally in the community for young people who identify as gender and sexuality diverse. So our social media marketing may have inadvertently tapped into that particular subgroup through the organisation. And also, it may be something to do with the algorithms on TikTok and the social media, in that something about our research connected with this particular group of young people, and it's likely to be because they are having significant difficulty getting their mental health needs met with our traditional services in the community. So just that there's a huge unmet need in this group. So we think that that is a combination of factors, but it did alert us to maybe some of the implications of relying on the Black Dog Institute social media channels as a recruitment pathway. And I've had reviewers on other studies where we're getting these high rates argue that they don't really believe the results because of how high they are. So I think that was just something that we learned And you can see there, the other interesting fact in this sample is that half had received therapy in the past. So here we have these young people who are they're 12 to 17, more than 50% had already gone to therapy and clearly hadn't found it to work. 1 in 3 had a previous mental health diagnosis, and a large portion of them had been on medication in the past. So it goes to show that there is this huge unmet need in young people. We always talk about who is in our trial, but I think it's as equally as to talk about who isn't in our trial. And these are the people that were not in our trial. So we had 3,200 young people complete screening. From those that were eligible, half didn't return parental consent. So that parental consent process was a barrier for young people getting into the trial. If you look here, most people were excluded because they were currently in treatment. So you can see how that would have impacted the trial if we had changed that inclusion criteria. And it was difficult. It took us a long time to recruit this. Well, not a long time, actually. It was under 12 months, but it took us longer because of that particular inclusion criteria. So you can see how researchers can like to make their inclusion criteria, or, you know, it does create barriers. We also had a higher attrition rate. So we had 25% attrition at primary endpoint and 38% attrition at the secondary endpoint, where we had been calculating on 20%. Okay, so what did we find? So essentially, you can see here that at our 6-week endpoint, we had a significant difference between the control condition and the 2 active arms, but there was no difference between the 2 active arms. So both unguided and guided were equivalent in their effect, and both were better than the control. But you can see when we get to 4-month follow-up, there's no significant difference that they merge back together. So essentially, the effect of Clearly Me is generated at that 6-week mark. In terms of the other findings, they mirror this pattern in terms of depression caseness as well. There was no effect for anxiety. So there was no difference between the control and the active arms for anxiety. And this is likely to do with the content, that the clinical content, it's missing the key ingredient of CBT for anxiety, which is exposure therapy. And therefore, we didn't get those effects for anxiety. All of the anxiety across all of the 3 arms significantly reduced. So essentially getting an SMS did help lower your anxiety. One of the things I also wanted to show was that Phil and I are working on a project at the moment which looks at what features that make trials informative. And both Phil and I, in our clinical trials, we always measure people's openness to this type of therapy, because I have seen it that a lot of researchers simply assume that because someone is signing up to their clinical trial, that they're actually open to receiving the therapy that's on offer. And we have actually found time and time again that there's many people in your clinical trial who actually are not open to receiving the therapy and don't think the therapy you're going to give them is going to work. And we know that treatment expectations have a big impact on outcome. So we measure openness to treatment at our baseline. And what we found in this particular study, you can see here, this is just the groups dichotomized into whether they have high levels of openness to receiving smartphone therapy versus low levels of openness. And you can see that in this particular, in those that were high levels of openness, there's a significant difference at 6 weeks between the control and the 2 active arms. And then you can see at follow-up, that significant difference with the SMS supported is greater than the self-directed. Okay, but you get the inverse effect happening over here. And in fact, there's no difference between the control conditions and the active arms in that group. So while this analysis is done after the fact, they weren't stratified in the randomization based on their openness to therapy. It does indicate that your preferences for treatment or the effectiveness of the intervention is going to differ based on your levels of openness. And if we hadn't met, and in fact, it's completely inverse. And so when we think about translating the findings into practice, that's a significant finding. And that's why we feel it's very important to explore some of those factors, because the treatment effect might be generated by something beyond your actual intervention. So in terms of the engagement, what do we find? So the whole point that we had the SMS chat arm was that we were hoping that young people would engage more with the app. And on average, we found that young people completed 2.2 out of the 9 collections. So they completed less than half, and they did 12 out of the 37 activities. So they didn't do very much. And there was no significant difference across the arms. So getting the support did not lead to completing more collections or more activities. What it did do was it made you more likely to complete at least one. So it looked like the SMS supported arm got you in, but it didn't do much more other than that. But interestingly, we do find this difference here. So you can see here, this is another scale actually that Phil was using before I was. It was in one of the first clinical trials that we were doing in teenagers at school, and we needed a sort of an easy scale to basically ask them, like, would you do this again? Would you tell your friend to do it? And it's actually emerged. I do it in every clinical trial, and it's actually given a bit of a benchmark over time of which digital mental health interventions seem to be mostly well received. And it mostly sits around 60% in young people. They would say they would do it again in the future. So my benchmark is if you're getting more than 60%, it must be pretty good. And you can see there that receiving Clearly Me with SMS support, a huge number of them were more likely to do it again in the future, more than just doing that on their own. So the SMS support seems to be doing something for future use rather than actual use or present use. And this is another one as well. We wanted to get a question, like a really simple item, and basically, did you think it helped you? And here, receiving the SMS support, those young people felt that the app helped them more in everyday life. So again, there seems to be something going on with that supported arm. We don't really understand the mechanism of its effect, but by asking questions like this, you do get a better understanding of maybe what some of those additives are in your clinical trial and how it might affect people. So another interesting thing about the clinical trials, a part of the work that my team does is looking around the harms of digital mental health interventions and some of the unintended consequences that might happen because of digital mental health interventions. And so you can see here, this looks at the number of people who reported adverse events across the study arms. And you can see there that young people who were in the active control were almost twice as likely to report an adverse event when compared to the active arms. And so what this means is that in your clinical trial planning, you really do have to plan that that particular arm is going to experience quite an elevated risk of adverse events, where in some other trials, it can actually be the intervention arms that have the more likelihood of risk. But in this particular trial, it's the control condition. And that on average, we got 1 in 5 young people reporting an adverse event. Interestingly, we had 13 requests for telephone calls. So even though we had 102 young people who would have been offered a call, there are only 13 of those who accepted that. So again, that gets you about that 2% mark. And really, I would argue that that's probably not the best safety monitoring procedure, and that we need to do more as methodologists in thinking about what is the best way to keep young people safe for that. So in summary for the results, you can see that MobiliseMe is effective for reducing depressive symptoms after 6 weeks of use. The guided support did not lead to greater reductions in symptoms or greater engagement. And as I showed you, those exploratory patterns suggest that self-directed use may be better for some youth and for some outcomes. And so when we think about translating this into practice, particularly around the next phase of this project is taking it into blended care, where a clinician integrates it into clinical practice, that essentially we would advise clinicians to measure the openness of young people to receiving this treatment. And it's often a question that we're asked, well, if they're not open to receiving smartphone treatment, why do they even sign up to a clinical trial? What are they doing in the clinical trial? And overwhelmingly, young people tell us the reason they've signed up to our trial is because they want to do good. They're there because they want to make the world a better place. It's not because they particularly care too much about the intervention. And so something that we always do in all of our trials is measure why did they sign up? And we get them to rate all of their reasons for signing up. And they also say that financial reimbursement is like the lowest, but I don't think that's entirely true. So there's some, you've got bias there. So what did we learn about this clinical trial? We learned something in every clinical trial, and we normally, I've made mistakes in every clinical trial, but I have to say this one was one of the ones where we wrote the protocol and then I went off and had a baby. So if there were any mistakes, I never knew about them. But it was one of the best that I've worked on. And it was truly enjoyable. And it was one of the most tightly conducted clinical trials. And I am really, really proud of it as a clinical trial. So I had to rack my brain around the lessons learned. But I think essentially this parental consent, all my work is done in minors. We have created through our work online Gillick competency measures. I've done legal reviews of how far you can get with clinical trials without parental consent. But essentially it's a barrier, and a lot of young people are not able to participate in meaningful clinical trials because of parental consent. And so looking at what is the most effective way to get parental consent for clinical trials, I think is going to be a game changer in clinical trials for young people. And unfortunately, it deters a lot of people from moving into adolescence because either they're IRB or they don't have the infrastructure to do this. So I think that's something that the field can really work out together. There is this bias in our recruitment, and how do we manage this, and how diverse is diverse? So when we're thinking about what sort of people we want in our clinical trials, who are we excluding and why should we be excluding them? And having, I guess, more careful consideration of the inequities you're reinforcing and introducing by not including participants. A lot of international researchers look to Australia for their adolescent mental health research because their IRBs simply won't allow them to look at suicidality in minors. And so we're actually one of the leaders in this space, but I still think there's a lot more to do around trying to get greater inclusion of young people who are really going through like incredibly tough times and having a really difficult time finding the treatment. Now, the instructions for use, it's bordering on, I think, irrelevant, because in our trial, we had less than 2 participants use the app the way they were instructed. So we spent all this time and all this effort creating these instructions for use, and nobody used it. In fact, we couldn't even measure engagement the way that our protocol said because nobody used it the way they were supposed to. So I'm not sure about the meaning of this in digital mental health. And the other thing is that it was designed in a way that was meant to be like a playground, as I said, but of course humans are so lazy that the majority of the modules or the activities they completed were the top 3. So I think that's something field, you're merging between medicine there, psychological medicine, but also the way people use digital technology. And I think we haven't quite worked out yet what the role of instructing people is in terms of use. Again, just the discussion around adverse events and control conditions and how to select the best control condition, and very careful consideration and getting a lot of feedback from a lot of different people about what is a suitable control condition. And I think the strength of this study is in its control condition. And so I think that's something going forward that I would certainly be looking more to in my planning, is quantifying adverse events. And again, we had some people that experienced a lot of adverse events. So I haven't looked at the data in terms of that once you've experienced one, you're likely to experience others. So just you get that spillover effect. There's a lot of operational challenges with monitoring adverse events. We face a lot of issues actually with employment contracts for having on-call clinicians to be able to manage the phone calls. And so there are a lot of operational challenges with your adverse events. And I have been involved, like I've heard around other clinical trials that haven't been able to offer a callback when they said they would because of these operational issues. And I think that's thinking about those challenges in the design is really important. And attrition, we tend to say conservative at 20%, but I'm starting to think that conservative really means 40%, and really rethinking attrition in young people in these digital trials. And again, measurement, like just stressing the importance of measuring the openness to the interventions that you're offering, and never assuming that simply because they've signed up to your clinical trial that they believe that what you're going to do is going to work. We had another clinical trial, again, Phil and I, we had a relationship app, and we had all these young people sign up for clinical trial. They got the app, and very few of them believed an app could help with their relationships. So it's such an important thing to measure. And last but not least, the most, I guess, unexciting is the costs. Everything in a clinical trial costs money, and you have to make decisions about things based on cost. So the guided support was around $150 per participant for the study. And a question mark remains, is it worth it? And how do you make decisions to balance cost in your design? And just thinking that through very carefully, and what the implications would be if we found guided support to be effective. Is $150 for a course of treatment something that's has economic benefit? Okay, that's it from me. Thank you for listening. I'm very happy for anyone to reach out with any questions about their clinical trials or any more questions about the intervention. I'm pleased to say that Clearly Me is due to launch to the public in May this year. So it will then be accessible for all young people across Australia to use. So thank you.